Modified radical mastectomy involves removal of entire breast, including nipple areola complex, along with the axillary lymph nodes, usually level 1 and 2, while preserving pectoralis major muscle. Consider this as a right breast model with nipple areola complex bounded superiorly by clavicle, inferiorly by inframammary fold, medially by midline of sternum, axillary tail of fence extending into axilla. In axilla, we have anterior axillary fold, which is formed by pectoralis major muscle, and posterior axillary fold, formed by latissimus dorsi muscle. Incision is planned according to location of tumor in the breast. For central or subareolar lesions of breast, classical stevet elliptical incision is used. For lesions in inner quadrants, obliquely placed modified stevet incision is used. For lesions in upper outer quadrants, classic Ors oblique incision is used. For lesions in lower inner quadrants and 6 o'clock position, vertically placed modified Ors incision is used. Teardrop incision is most commonly used, often with narrow end oriented medially, designed to minimize lateral dog ear deformities and allow better access to axillary region. Patient is placed in supine position, arm abducted 90 degree on arm board and sandbag placed behind ipsilateral scapula. Elliptical incision is made including nipple areola complex and skin overlying breast tumor with the skin margin slice 1 to 2 cm away from the tumor. Incision should be away from the midline medially and doesn't cross anterior axillary fold laterally. Incision deepened up to subcutaneous tissue. Skin edges are elevated at right angle to the chest wall for adequate exposure. Plane of dissection is between subcutaneous tissue and mammary fat. Upper flap is raised up to clavicle medially and laterally we can see cephalic vein in deltopectoral groove and acromial branch of thoracoacromial artery, which is the superior limit of dissection. Flaps should be thick enough to include subcutaneous vasculature but does not include breast tissue to avoid seroma formation and skin necrosis. Lower flap is raised up to 2 cm below inframammary fold. Rectus sheath forms the inferior limit of dissection. Medially, flap is raised up to midline of sternum. Laterally, flap is raised up to anterior margin of latissimus dorsi muscle. The breast tissue is dissected off from pectoralis major muscle, starting from medial aspect, moving towards laterally. Perforating branches from internal mammary artery are identified and ligated or cauterized. Pectoralis major fascia is included with the specimen to ensure clear deep margins. Dissection is performed up to complete visualization of lateral border of pectoralis major muscle. Major blood supply of breast is from perforating branches of internal mammary artery or internal thoracic artery emerges through 2nd to 4th intercostal space. Branches from lateral thoracic artery and lateral cutaneous branch of posterior intercostal artery supplies from lateral aspect of breast. Pectoral branch of thoracoacromial artery supplies superior aspect of breast. Following the elevation of breast parenchyma, an in-continuity axillary dissection is performed. Clavipectoral fascia forms an important anatomical boundary between breast tissue and axillary contents. Clavipectoral fascia is sharply divided to define pectoralis minor muscle. Dissection is performed along lateral border of pectoralis minor muscle. Medial pectoral nerve, along with pectoral branch of thoracoacromial vessels, lies along lateral border of pectoralis minor, is identified and preserved. Pectoralis major muscle is retracted upwards and interpectoral or rotose group of lymph nodes lies between pectoralis major and minor muscle are removed. We can see two nerves entering pectoralis major muscle. Medial pectoral nerve lies laterally along with pectoral vessels, pierces pectoralis minor muscle and supplies pectoralis minor and lateral or sternocostal part of pectoralis major muscle. Lateral pectoral nerve lies medially, pierces the clavipectoral fascia and supplies medial part of pectoralis major muscle. The name medial and lateral is not its anatomical location, but it indicates arises from medial and lateral cord of brachial plexus. Injury to these nerves result in atrophy of pectoralis muscle and difficulty in shoulder movements. Pectoralis minor is dissected till its insertion to coracoid process, where underlying axillary vein is identified. Careful sharp dissection is used to clear adventitia from axillary vein. Usually 4 tributaries draining into anterior or superficial surface of axillary vein is seen that can be sacrificed. Dissection should not extend above the axillary vein as it may increases lymphedema formation and unnecessary exposure of axillary artery and brachial plexus. Level 1 axillary node include 3 groups. Lateral or humeral group lie medial to axillary vein, drains upper limb. Posterior or subscapular group lies along the dorsal scapular vessels. Anterior or pectoral group lies along the lateral thoracic vessels. Level 2 axillary lymph node include central group which lies behind the pectoralis minor. Dissection is proceeded from axillary vein downwards. Lateral thoracic vein along with its artery is identified in the medial aspect and individually ligated and cut. It can also be preserved. Key note in this dissection is any veins draining on anterior or ventral surface of axillary vein is sacrificed, and any structures going in posterior or inferior aspect of axillary vein is to be preserved. Tributaries of axillary vein are either cauterized or ligated and cut. Dissection is proceeded downwards from the axillary vein. Intercostobrachial nerve is visualized. Emerging from second intercostal space, runs horizontally, provides sensory supply to upper medial aspect of arm and axilla. It can be sacrificed if oncological clearance is not possible. Thoracodorsal nerve and its associated vessels are identified along lateral aspect over subscapularis muscle. Dissection proceeded downwards along the lateral border of latissimus dorsi muscle till visualization of angular vein. Angular vein is the lower limit of dissection. Medially, we can see long thoracic nerve or nerve to latissimus dorsi lies medially over serratus anterior muscle. Careful dissection is performed along this nerve. Injury to this nerve leads to winging of scapula. Nodes in between serratus anterior and subscapularis muscle are carefully dissected as it may be missed and this area is difficult to irradiate. In axillary dissection, level 1 and 2 axillary nodes lies lateral and posterior to pectoralis minor muscle are removed en bloc along with breast tissue. Boundaries of axillary dissection includes superiorly axillary vein, inferiorly angular vein, medially long thoracic nerve and serratus anterior muscle, laterally thoracodorsal pedicle with latissimus dorsi muscle and subscapularis muscle forms posterior limit of dissection. Level 3 nodes are not routinely removed and indicated only when there is cross lymphadenopathy or clinical suspicion of apical involvement. Pectoralis minor muscle is retracted superiorly and level 3 lymph node dissection is proceeded. Cephalic vein draining into axillary vein is seen superiorly and medially we can see Halstead ligament or costoclavicular ligament, which is the medial condensation of clavipectoral fascia which forms apex of axilla. Level 3 axillary node include apical or infraclavicular group lies medial to pectoralis minor and its involvement is an upstage disease with the N3A classification. Lymph nodes in this area can be removed separately or en bloc with other group of axillary nodes. Some surgeons retract pectoralis minor laterally and pectoralis major medially for exposure of level 3 node. Boundaries of level 3 axillary node dissection includes axillary vein superiorly, Halstead ligament medially, pectoralis minor laterally and chest wall inferiorly. Superior thoracic vessels lies in this area which can be preserved. There are 3 techniques for exposure of level 3 nodes. In Patty's technique, pectoralis minor muscle is removed completely. In Scanlon technique, pectoralis minor muscle is divided near its insertion. Auchincloss technique is most commonly used and in this pectoralis minor is retracted for exposure of level 3 node. After axillary lymph node dissection, complete hemostasis is achieved. Irrigation and suctioning is done. 2 suction drains are kept, one in axilla and other in chest wall and fixed to skin. Subcutaneous tissue and skin closed in layers. This completes modified radical mastectomy. Thank you.